Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record, and also please remember to fill out the program evaluation, which today is a paper evaluation. And if you have any ideas in regards to future topics or future speakers at Grand Rounds, we'd appreciate those. Today I have the pleasure of reintroducing Dr. Selden Spencer. Dr. Spencer is a neurologist, a member of the departments of neurology at Mary Greeley and McFarland, and polysomnographer extraordinaire. And he is here to conclude his series on a review of the cranial nerves. So please join me in welcoming Dr. Spencer.
Great. Thanks, Steve. All right, this is great. Really appreciate you being here. This is the brave and strong are here to finish up this talk. As you recall, the previous talk was on the first couple of the cranial nerves that really fell into more of a neuro-ophthalmology view and perspective. This will be the back nine, if you will, in golf. And it's a lot of bread and butter things that we all run into as clinicians, and hopefully this will be useful to you. But I think there's always some new insights on it that might be helpful. All right, a lot of anatomy, but we'll see how it works. So again, to kind of go back over where we were, the previous talk addressed some of the rostral cranial nerves, the olfactory nerve, oculomotor, ophthalmic nerve, optic nerve. But now we're going to focus on these big nerves in the back, again, to remind you about some of the crucial bony anatomy that bears on this for cranial nerve 5. And as we get back here, 9, 10, and 11 all seem to hang out with the foramen, jugular foramen, and then the hypoglossal nerve has its own little place. And then again, the dizzying relationship of all these nerves. We spent our time talking about this before, and now we're going to spend time talking about the trigeminal nerve and the facial nerve, which are basically sensory and motor, but a lot more than that. And then the 8th nerve, and then couple the 9, 10, and 11, 12 toward the very end. I thought it took a minute just to talk about a nerve and what a nerve looks like and how the nerve works. Just to, and it doesn't matter whether we're talking about your leg or we're talking about the cranial nerve. You have both unmyelinated nerve fibers and you have myelinated nerve fibers. That is a unique feature of the cranial nerves, as opposed to anything in the brain, that you have this other cell type called the Schwann cell, and hence you hear the term schwannomas when they become cancerous and crowd out everything. So you have these lovely fascicles surrounded by epineurum, which has a knot of vasculature. So to go back to cranial nerve 3, when you have problems with circulations from diabetes to the nerve, you wipe out the nerve on a circulatory basis. All right, so onwards. Trigeminal nerve, very big and complicated. This is a nice picture from Grant's Anatomy that says, oh God, what the hell is going on here? There's just too much stuff. But if you break it apart, you can get some very simple, and this is what we like to think about, which is just trigeminal first division, second division, third division. And that is pretty clean. And for you, as in the office, if it's behind the ear, it isn't the trigeminal nerve that you're entertaining as being a part of the problem. I love this picture down here because it looks like worms are coming out of your head, and these are actually individual nerves of the trigeminal system. And this is relevant. I think you're going to see down the line that when we talk about trigeminal neuralgia, some of the interest now is on the bony anatomy, how these nerves exit, and indeed maybe it's more of a bony problem than something wrong with the nerve itself. But there is a motor element, very simply addressed primarily with the pterygoids, and that's just bringing your jaw back and forth. So if you're wanting to look at the motor portion of the trigeminal nerve, you would do that. But then there's these very tiny muscles, the tensor tympani, which has a lot to do with controlling the volume of your ear. And then a lot of interest in the levator palatini and other obscure muscles in the palate that are important for swallowing. And then a lot of random tissues. So you get sensory output to the brain from the tear duct, from the, not the tear ducts, but tear gland, salivary, But this is where it's relevant to migraine and headache. Everything from your sinuses, your teeth, your tongue, meninges, feed into the trigeminal system. And that's why a lot of interest is focused on what you can do to dull out that system in pain syndromes. Now this is a picture of trigeminal V2 problems, and it's not really real. These people are miserable because she's got her eye open, and as you'll remember, anybody you see with trigeminal neuralgia, usually their eye is closed. They're miserable. They're holding their face. But there's a lot of curiosities in terms of neurophysiology here. First of all, when you're wondering about trigeminal neuralgia, it's fast staccato injury. It's pop, 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 pop. That's what it's like. Oh, they're just holding their face. And the interesting part of that is then there's this refractory period. It goes on, it can go on for a minute or two, and then it just stops, and it can't be triggered. Even if you touch that affected part, if you brush the cheek or have them touch the tongue to their buccal mucosa, you can't trigger it. Very curious physiology. But it's also useful in trying to make a diagnosis and be confident about what you're dealing with. But as time goes on, the remissions get shorter, the attacks get longer, and things get very difficult. You just have some numbers there. It's a nice reference if you wanted to kind of go over it yourself. As time goes on, you can get into facial spasm or problems with the motor component of the seventh nerve. Now, what else could it be? And I just go through the differential. There is all these trigeminal autonomic cephalgias, and I think I've talked about them before, and the difference is the attacks are shorter and there's an autonomic element. Are they tearing in their eye? Is their face flushed? And there's an argument back and forth whether it's all sort of the same thing, but regardless, sometimes being a little bit more precise in your diagnosis is helpful. You're going to address these probably less with an anticonvulsant and more with calcium channel blocker. Obviously, temporomandibular joint, you should be able to elicit by palpating around the jaw. It won't have that characteristic staccato and then refractory period. Herpes zoster, problems with the teeth. The whole relationship with MS is very peculiar. It's kind of a traditional thing that we think about, that trigeminal neuralgia is more common in MS, but I think that's open to question. I'm not sure that the recent data really is very supportive. Obviously, trauma to the face and to the nerve can generate pain that you'd have to differentiate. Now, some of the interesting thing, and I kind of listed some references here, and for the pleasure of Dr. Powers, I do have some pathology here that we'll take a look at here, but the big trend is to look for neurovascular compression, and I'll show you some pictures down there with the idea that pulsations of the posterior inferior cerebellar artery on the trigeminal nerve causes trigeminal neuralgia. But there's plenty of evidence that this is allergic. You see mast cells prominent in the area. And then, as I told you before, bony anatomy is very important. There are articles that talk about the exit of some of these nerves being the problem for trigeminal neuralgia. And then how much of it is central? Why does it progress? And there's even some people that have sagging brains and a basilar impression causing problems. So here's your brief pathology, and you have the reference there. If you take a little chunk of the trigeminal nerve, even from far away, you can see this is rather pale. This is more clustered up, and if you get down on the electron microscopy element, what you want to see is the myelin around the axon like that. That's not too bad. This is actually pretty good. This isn't real good, and this is terrible. This is pretty much unmyelinated, and these axons are pretty much lying on top of one another, and hence the whole theory of ignition. That is, you lose the myelin, these axons are kind of laying together, and whether by chemical mechanisms or by electrical mechanisms, you get the random firing, exhaustion of the nerve, sits quiet for a while. I didn't mention bioresonance is another theory out there. But anyway, this is a more traditional appearance of the patient you'll see with trigeminal neuralgia. They're just miserable. They're very uncomfortable. And one of the things, and we'll do some imaging, is you see pressure of the artery on the nerve. Now, nothing is ever clean, and there was a recent cadaveric study showing that vascular pressure on the nerve is quite often on the opposite side of the trigeminal neuralgia, and so on, so on, so on. So it's not a clean relationship, but nonetheless, there is validity to it. And if your medicines fail, you are going to be talking to people about microvascular decompression. But obviously, you're going to do an MRI, and if you unfortunately see some kind of a meningioma or a schwannoma investing the nerve, then you got a problem. But more commonly, you're looking for, and you're dependent on a radiologist to tell you that you have a vascular compression on the nerve. And then, if your medicines fail, you are going to get help. So here are the good news, bad news. You have a fair amount of success rate with anticonvulsants. Carbamazepine is the old traditional one, but gabapentin sometimes is a little bit more comfortable for people to use. And you have a good success rate, but you will have failures as time wears on. Neurosurgery has a very, and this is just my gloss, that it has a very good success rate, again 80–90%, but half recur. And then other more destructive processes or gamma knife lesioning, I was talking about microvascular decompression there, has a similar pattern. And then sometimes you unfortunately see people with totally numb face, but misery pain. And I'm dealing with one right now, and it's almost certainly largely a brainstem problem. It's not a nerve problem at that point. So, yeah, I just have to throw this in. This is a guy I've followed since the 90s with right facial pain, obedient to B2, pretty traditional trigeminal neuralgia, and it was wind that would really drive him nuts. Any kind of wind would just drop him to the ground. But it was all controlled. He'd actually been up to Mayo at some point or another. I think the date is wrong here because this is just recently in the fall. But I thought this was kind of amusing. He was pulling on an auger, fell back, really whacked his head, doesn't have pain anymore. He's off meds. I'm not advising this as a treatment, but it's just, there's a lot of curiosities about these nerve pain problems, and you probably all in your own experience heard something of this sort. So, on to cranial nerve 7. And best to kind of think about it as 4 parts. The easiest part for us to remember is the part that controls your face and the facial muscles, right? But this is a nice slide that emphasizes that you have sensation to the ear from the 7th nerve. And if you remember things like zoster investing the ear, that's pretty traditional. You have sensory elements. I mentioned that already. But also sensory elements to salivary glands, and then taste elements to the tongue. This is a picture from Bell, of Bell's palsy fame, and it's his original, 1830s efforts to map out the anatomy of the facial nerve, just for interest. Pretty scary looking. That was before institutional review boards, right, Larry? I think that's right. So we do have then these simple pictures, but the reason I threw this out is because the motor element really is different from nervus intermedius. Now, I don't think you're ever going to kind of parse this apart, but being aware of the nervus intermedius and its role as far as parasympathetic control of tearing and salivation is worth keeping in the back of your mind. Now, this is, again, a Grant's anatomy picture, and the only thing I really wanted to emphasize out of this, other than, geez, it's horribly complex, is that there's a long bony element. So we have the facial nerve getting into this petrous bone, going on and on and on and on, and exiting now bound below your ear. So it's a long journey in the bone. And that's where we think Bell's palsy usually takes place, that somewhere in that bone there's a swelling of the nerve, damage to the nerve, and hence, trying to be clever with the ER doctor calls me, I say, well, do they have lost taste in their tongue? Because if they have, then you're thinking a lot about where the chorda tympani is, and that if the taste is preserved, then the damage was distal to the chorda tympani. That's okay, we'll just go ahead on this. So I thought this was a nice slide because colors help, right? So if you can look then just at the yellow part, you're looking at motor control. If you look at the orange part, you're looking at the glands. And then if you look at the green part, you're looking at sensation. And blue is general sensation over the years. So just some pictures of Bell's palsy. Again, pretty easy to see that there's some droopiness on this side of the face. This is a little more severe and it has the Bell's phenomenon with the inability to raise the eye. Or it folds back, I'm sorry. So this just some numbers and incidents that you can review. Interesting that pregnancy is a common, or at least a little more common to occur. There is this grading scale. And again, as I said before, is there hyperacusis? Is there loss of taste? Is there a dry eye? These can all go along with the nerve. And of course, in the emergency room, you're always struggling. Is this a stroke? Is this person's face weak because of a stroke? You can tease it out with some of these other features that could be very helpful to reassure all parties. You're still going to do all the imaging, I suppose. But anyway. So what is the cause of Bell's palsy? The bulk of information resides around herpes simplex and viral mechanisms. But there's a strong argument to make it like a mini Guillain-Barré kind of syndrome, where it's just an immune freak out of some sort or another. Like anything else, you can have a circulatory element to the nerve. Very commonly, Lyme's disease, sarcoid will go after that nerve. So a lot of different mechanisms that can be invoked and considered. You don't do anything, they get better. Now, if the usual thing is it gets worse over 3 days. So if you see them within 3 days, there's a lot of interest in trying to treat them and trying to help people with this. And in that regard, the only thing that's really been documented very well is prednisone. I think we've fallen into the habit, everybody, based on rather limited information, that we give them acyclovir as well. The evidence that that is true is small, but any more medical legally, I think we all do that, for better or worse. There is a recurrence. As I said before, there's some genetic element, and those are the people that will recur. And if they're still bad, they're in that unlucky 15%, 6 months, 1 year out, then they're just basically left with plastic surgery. I wanted to throw this in because I've never seen a case, and now I've seen a case. So a 49-year-old woman with sudden onset of left ear pain with blisters, that was September 2013, slowly evolved into stabbing left face pain and ear pain. So pain you don't really think about as the facial nerve problem, but this person has a swollen, weak left face and a very painful left face. And she's miserable. Let me see. Okay, so so she went up to Mayo and they did all their things, and she came back here, and we're still trying to work with her. We think that's the correct diagnosis, and I think just for kicks, just because of the curiosity of medicine, what would be the diagnostic test for Melkerson-Rosenthal? It's endoscopy, because it's so commonly associated, or colonoscopy, I should say, is so commonly associated with Crohn's disease. So it's kind of a weird kind of an immune problem. This is my patient. This is her misery that she deals with every day, and she is slowly getting better. It's a very uncommon condition, and they do tend to get better, but they take lots of steroids off and on, and lots of pain medicines and anticonvulsants to try and settle down the nerve. So on to cranial nerve 8. Obviously, the two things are balance and hearing, and it's all special sensory, no motor component, and you can read the rest. So we're dealing with lots of conditions that you guys are dealing with every day. What's happening with somebody's balance, vertigo, ringing in the ears, nystagmus, all these issues that may pertain to the cranial nerve 8. So some pretty pictures of the anatomy and the complexity thereof. So if you can orient yourself, this is the cochlea, which is going to be all your hearing, and feed into the, this is the cochlea feeding into the nerve with the semicircular canals and the saccule and the utricle feeding into the nerve. Very precise, very well organized phenomenon. Tightly residing with the facial nerve, too, which makes life interesting. Again, just trying to highlight that relationship. So, vertigo. I want to emphasize it's not necessarily dizzy. That's where we always start. We all start with dizzy. We have to make sure that it's not faint. Are they losing consciousness? But it does have to have that spinning element to it. Very common. 5% of people every year. Over a lifetime, 30% of us will have episodes of vertigo. And I just threw that in to wake you up. And this is not Cary Grant's vertigo. This is the neuroanatomy vertigo. And there is some parsing into this, and I'm going to dig into it just a little bit, but not a whole lot, because I want to stay a little bit more practical. If you look at what literature I looked at, there is a priority of what's most common. And the one we all know about, benign positional vertigo, is number one. Meniere's kind of goes back and forth between migraine, and we'll talk about that. But migraine is the one that I want to emphasize, and this has been true in my experience just as I've gone along in practice, is vertigo as a manifestation of migraine is a real deal, and it has to be considered. The last one is vestibular neuronitis, which would be a true cranial nerve disorder. So what I think about in terms of differential is you've got to have a positional element for benign positional vertigo. If they cannot tell you that I get into this position and I have my problem, you want to be thinking about some other diagnosis. Meniere's, you want to think about the tinnitus and hearing loss, and it is a bear, but it's kind of slowly progressive as time goes on. And I can't tell you the number of times that people have been labeled as Meniere's early on, and then subsequently, 5 years later, they manifest something else, and oh, well, it wasn't Meniere's anyway. But migraine, as I said, quite often kids will tell you they had motion, or the patient will tell you, yeah, when I was a kid, I had a motion sickness problem in the car. Also, I couldn't go on merry-go-rounds. I couldn't, so they had problems with sensitivity of the vestibular nerve early on. And of course, the bear in the emergency room, is this a nerve problem, like the facial nerve or the eighth nerve, or is it a brain problem? Is it a brainstem stroke that we're dealing with? I just would emphasize that, surprisingly, if it's due to the nerve, they usually don't have a lot of gait problems. They're not walking funny. And then we'll talk about nystagmus in a bit. Vestibular neuritis, it comes on just like a Bell's palsy would come on, and nothing makes any difference. They're just miserable. It doesn't, not dependent on position, and they are just always feeling like they're moving, and they pretty much try to pin themselves to the bed and stay on the bed and stay there. So again, just a brief thing, again, for your handout, trying to separate central versus peripheral. Usually the peripheral is more sudden, everything's relative. For my purposes, the nausea and vomiting doesn't help, I don't think. But the motor part, I think, is worth considering. And you will try to make your decision whether you think on a clinical basis it's central, based on what they're doing with their arms and legs and their walking. One little picture to kind of analyze a little further, and I think it's just kind of interesting to think about the utricle and saccule as being very much involved in the linear quality of our moving forward and backwards, whereas the semicircular canal is used to our angular position in space, and all beautiful anatomy and interesting things going on with that. But they're two different sensations. Okay, so what do we know about benign paroxysmal positional vertigo? Most common, females, you see the age. oddly associated with osteoporosis. And now Tim is going to help me, but this is a beautiful set of videos from the New England Journal. And you have to give me some credit for not torturing you with this whole thing, because we're going to just kind of show a little bit of this, because you can analyze which semicircular canal is involved, but I just wanted to kind of go through this a little bit here.
Video 1 shows the Dix-Hall Pike maneuver and the typical pattern of nystagmus in benign paroxysmal positional vertigo involving the right posterior semicircular canal.
Remember, right posterior.
With the patient upright, the head is turned to the right side about 45 degrees. Then the patient is moved from the sitting to the supine head-hanging position with the head about 20 degrees below the end of the examination table. During this maneuver, the orientation of the right posterior semicircular canal lies in the sagittal plane, and the free-floating otolithic debris in the posterior canal move down and away from the ampulla. The resulting nystagmus is upbeating and torsional, with the upper poles of both eyes beating toward the lowermost right ear.
That's great. And he sounds better than I do, too. It's great. So anyway, this is the real deal. And, you know, honestly, I'll be honest, I don't do this. I quite often ask the physical therapy, if my clinical suspicion is strong enough that this is vestibular, I'm going to have the physical therapist help me out. We have very good people with this.
For Canalith repositioning to the right side.
But if you want to.
Head is turned 45 degrees to the right side. The patient lies back. The examiner can observe for the nystagmus. That position is then held for 15 or 20 seconds. Then the head is turned 90 degrees toward the unaffected side. And then the patient is manipulated so that the head is facing the floor. And that position is again held for about 20 seconds or so, after which time the patient can sit up.
Short and sweet. Okay, and then you have a visual in your handout that would go over the beat it to death one more time for you. So Meniere's, again, classic thing, sensation of ear fullness, vertigo, episodic, and progressive. And I think that's what you have to keep in mind with this regard. Just a picture of Meniere's disease, normal semicircular canals that just blow up over time. That's where the term hydrops is utilized. Mechanism is unclear. We don't know why this happens in some individuals, unless somebody else does. Sorry. I already kind of went over the key as far as migraine, fish around from an old history of motion sickness. And again, these are going to be episodes that come and go, and they may or may not have headache associated with them, but you would certainly approach it in a different fashion. You'd probably use beta blockers and tricyclic antidepressants to help. Neuronitis, I gave you the basics here. I think you're really dependent on physical therapy, and you can try different symptomatic care. You can use benzodiazepams to try and help them with their misery. There is a sense of using, and I gave you the reference, Solumedrol for 3 weeks in a tapering fashion. Not sure that makes all that difference. Okay, what about ringing in the ears? Very common. I would really refer you to this. This is amazing. I went through this article, and everything in the world you can imagine this guy has thought of. Again, I feel like I'm punting everything to physical therapy, but there are a number of people with tinnitus that it's on a musculoskeletal basis. It is something with neck musculature that if they position their head one way or another, they can create the ringing or the noise in their ear. And to that extent, analyzing them and having work on neck musculature can minimize the experience of tinnitus. I think, you know, our tendency, particularly in neurology, oh, you got tinnitus, don't worry about it, there's nothing bad. The one time we do worry about it is that when it links with the heart and it's pulsatile, doom, doom, doom. Then we start thinking about it a little bit more as being a manifestation of something serious in the head, and for which we will probably do some imaging. So My buzz on nystagmus is if it's vertical, you worry about it, the traditional teaching in neurology. If it's all up beating, it's rostral in the brainstem. If it's all down beating, it's posterior in the brainstem. Horizontal, you want to know whether it's fast or slow, and I got some videos coming up here that will highlight that better than I can do. I put in intranuclear ophthalmoplegia because if you see nystagmus with just one eye, you want to consider it being more brainstem. With both eyes, that's more happily looking at the vestibular structures. See, did we do this already? Yeah.
With the patient seated.
These are highlights. Did I do something wrong? Yeah, probably. Here we go.
With the patient seated, turn their head 45 degrees toward the side of interest.
This is just
and lay
look at the
them down
nystagmus
quickly.
more than anything else.
Extend the neck 30 degrees from the horizontal. Observe for nystagmus for at least 30 seconds. This can be repeated on the opposite side.
I thought I had a close-up. Okay, let's move on. This is the,
In this
There we go.
positive Dix-Hall pike, notice that the patient initially has no symptoms,
dizzy.
and then after a few seconds,
I'm very dizzy.
she says she's getting dizzy.
Good.
This is called the latency.
Stay there. You're doing a good job.
Also notice that after 15 or so seconds, her nystagmus and vertigo improves.
Is it sort of gone away now?
Yeah.
In this slow motion video, you can clearly see that the nystagmus is vertical with upward beating eyes and a torsional component towards the downward, in this case, the left ear. In this patient with vestibular neuritis, notice how when he looks to the left, he has large magnitude nystagmus. When he looks to the right, it almost completely disappears, except for several small beats, which are occurring right now.
Can I look back the other way?
And when he looks to the left again, they increase in size again. This is called Alexander's Law, and this is a very typical finding in vestibular neuritis.
I really like the last one that he's going to show you here. Or maybe that's it. Okay. The last one was a patient in the emergency room that, which is more common. I think probably see the paramedics up there. The more common thing is you have a guy in front of you and the eyes are going over here and then they're going over here and look to your left, look to your right, and they're shaking all over the place and their alcohol level is like 4.0 or something like that. So, you know, drugs obviously are something that you want to consider in a nystagmus kind of circumstance. So now we're going to rush through 9, 10, 11, 12. We'll try to give them courtesy because they usually don't get a lot of courtesy, but we'll talk about 9 first, which is your glossopharyngeal nerve, but a very complicated nerve. And all I want to try to show you here is that you do have a motor element that goes out to your throat, so it has everything to do with swallowing. And then you have a sensory element that goes from your carotid sinus. In the day past, I thought all hypertension was due to a problem with the glossopharyngeal nerve, but that's probably not the case. But it does have a role in special sensory abilities. So it's all about swallowing and breathing and hoarseness, and practically speaking, I'm interested in cranial nerve 9, primarily with glossopharyngeal neuralgia. But when you have a person with swallowing or hoarseness or problems of that sort, I think the best test is just having them go ee, try to see if they can oppose their vocal cords as a means of testing that cranial nerve. When it comes to 10, we spend a lot of time looking at the uvula and the back of the mouth, whether it's deviated one way or another. That's great, but that's only one portion of that vagal nerve, and it may or may not help you. It helps you if the injury is up high. If it's hoarseness alone, you actually could be dealing with a part of the cranial nerve 10 that goes down around the aorta and comes back up, the recurrent laryngeal nerve. 11 and 12 are There is a central pattern generator, and I talked about that with walking before. And all these cranial nerves are involved with a central pattern generator that allows us to swallow and to phonate without thinking about it. Jugular foramen is the bony element here. So all these complicated nerves are going through the jugular foramen and are vulnerable to compression. I've never seen it. I'm sure it exists out there. Maybe some of my colleagues have, but you can get meningiomas, paraganglionomas, all kinds of things that once it's in that foramen, it compresses all the nerves and creates a lot of problems. So glossopharyngeal neuralgia, again, fairly infrequent. You would manage it the same way with anticonvulsants. Just something to think about as you're working them up. You probably are going to image at some point or another, but something you would think about with sarcoid or Lyme's disease. And I showed you earlier, cranial nerve 10 has these peculiar relationships with the pharynx and the larynx, but also all these other organ systems. It's too complicated to beat on today. I already mentioned that. I have seen one case in the Eagle syndrome where the styloid process was so long that it did press on the glossopharyngeal nerve and caused intense pain, and it went in and got trimmed and they were better off. But on my roll of things, we usually wind up using anticonvulsants. There is literature about microvascular decompression for those type of neuralgias as well. Finally, a simple nerve. All motor, spinal accessory, purely goes out to muscles in the neck. There you go. And I don't see this as being a big issue, but it would be very, I don't know that I've ever seen a case of just an isolated cranial nerve 11. David, Anu, either of you? Nope. But hypoglossal nerve, totally different part of the bony anatomy, and pure motor again. So again, what you would look for is something obvious like this: atrophy, damage, and then finally, ALS is always a concern, and I think we have a video of what ALS would look like with the tongue. It's just writhing and rocking away and atrophied. Okay, so the end of the show, cranial nerve can be a potential site of injury. So you come in with patients with these different complaints: vertigo, imbalance, tinnitus, facial pain, facial numbness. You have to consider the cranial nerve as a nidus, not just the brain. You look for neighborhood signs to try and pin it down. You're always going to wind up doing a lot of anatomy, looking at the skull and bony canals. And I touched on, and you have in your handout, all the pathologies that might be involved with that. And I don't even have a thank you question slide, so this is the end of the talk. No, thank you very much. Oh, I do. Okay, sorry, I'll take it back. Okay, David. Yep. Yep.
Do you recommend imaging for Bell's palsy, or for vertigo and tinnitus?
All right, so for Bell's palsy, if I'm confident that the forehead is involved, meaning that it's more likely to be peripheral in nature, then I'm not going to image probably for a month. But if it gets out to be a month and they're really, or if they're steadily getting worse, then I'll pull the trigger out a week or two. Now, as far as vertigo, I kind of teased through some of the things that I'm thinking about for vertigo. If you have a 60-year-old person who has diabetes and has risk factors for stroke and vascular disease, then I'm going to be a lot more likely to spring to imaging than if it's a 20-year-old or a healthy 40-year-old that doesn't have any other risk factors. So that's kind of, what, do you have any sense or guidance yourself?
I just think that it's something to bring up or to talk about, because I find most people ordering tests very early when it's like classic Bell's palsy, and it doesn't really get you anywhere. It just
Well, it gets you a little reassurance for the patient, I guess, depending. But anything else? Oh, Angie, okay.
On the topic of Bell's palsy, so if they're seen in the ER, what is a good time frame for them to be seen in the clinic? Since you said that 85% of the symptoms will go away.
A month, yeah.
And so, I mean, should you wait past a month? Or?
Yeah, I mean, I usually, you know, I think most of the primary care doctors wind up taking care of these. You know, so neuro doesn't get involved usually unless it's out. Although we have, I guess, in the past, haven't we? They're all nodding their heads. Okay. You know, it's pretty distressing to the patient, and a lot of what we do in neurology is try to reassure people that, yeah, this is going to get better. Don't worry about it. So I guess ER to neurology, a week or two. Does that sound okay? All right. Well, good enough. Oh, you have a question there, or are you scratching? Okay, good. All right. Thanks a lot. Appreciate it very much. Bye-bye.